Hello, this is Dr. Joydeep Chaudhary with Academics in Nutshell. We will discuss some bizarre injuries that might happen in children. Button battery ingestion has become more common recently. Majority of the button batteries do traverse the GI tract uneventfully, and complications arise only if the battery gets lodged, and particularly in the esophagus. It may have corrosive effect due to the acid content of the GI tract or due to the electric charge that it releases, which may cause caustic injury, or it may have toxic metal effect due to leakage from the battery itself, mercury and lead and etc., and it may cause systemic toxicity. Now if there is a complaint of button battery ingestion, then one x-ray has to be taken. If the battery is visible beyond pylorus, then one has to just give laxative, observe the child whether the battery comes out through the stool. If the battery is lodged in the esophagus, then it's an emergency and it should be removed by endoscopy. Now, if the battery is in the stomach but before pylorus, then the child has to be admitted, observed, a repeat x-ray taken. If the battery moves beyond, then it's fine, one has to observe. But if the battery is not moving, then one may have to go for emergency removal and proper management. Electric burn is another common injury. There are entrance and exit burn. The internal injury is usually more than the surface injury in electric burn. Now, baseline 12 lead EEG should be done unless the injury is very minor. Cardiac monitoring if ECG is abnormal or there are complaints of chest pain or impaired consciousness. Analgesia may be required as it's very painful. Fluid therapy and management of myoglobinuria, if required, has to be done. Any child with high voltage injury, evidence of cardiac or neurologic abnormality or any other complication should be admitted. Asymptomatic child with low voltage injury with normal ECG may be discharged after emergency management, and ideally all the plug points in the house should be covered. The naphthalene or mothball ingestion may cause severe hemolysis in G6PD deficient patients. The lethal dose is 5 to 15 milligram. Initial management is activated charcoal, most effective within 2 hours. If there is hemolysis, packed RBC has to be given. In some situation, forced alkaline diuresis has to be employed. Milk and fatty food should be avoided as it facilitates absorption. If required, hydrocortisone to prevent hemolysis or management of methemoglobinemia has to be done. The penile zipper entrapment injury is a very critical condition because once entrapped, attempts of unzipping for self-extrication complicates the situation. It is an extreme painful. The movable zipper head and the interlocking teeth may entrap some of the soft tissue. The only management is the removal of the median bar. The median bar is the structure which separates the two tracts of the zipper sliding as shown in the photo here. It has to be cut with a bone or wire cutter and then released. If not possible, better to take to a pediatric surgeon. Paraphimosis is the edema of the foreskin that develops due to forceful retraction of the foreskin. Easier to reduce the foreskin early when the edema is less. The child may be given analgesics as it is painful. A gentle digital pressure on the foreskin through a saline soaked gauze may reduce the foreskin and edema to some extent, and it may give relief. But if it fails, better to refer to a pediatric surgeon early. Thank you.